Thank you so much. It's my great pleasure, and specifically great pleasure to be here in person. I'm so sorry I will be talking in English. My Spanish is very basic level, but I hope it will work for all of you. So, yeah, thank you so much. It was extremely complicated year, and now I already can talk about this without these emotions are still there. However, we learned how to focus on something what would be the best from each situation which is happening. So the team suffered, we suffered. The situation with the biological materials was extremely complicated for us. However, we learned how to guarantee the safety of these materials and how to continue helping our patients, keeping all our team being involved and even giving them the opportunity of how to grow and how to develop. So I will tell you, and this is all because of the facts that we've been in Ukraine, we've been dedicated a lot for the international patients. In last maybe 5 to 7 years, this changed a lot. And Ukraine being in a map nowhere, because until this tragical situation happened with Russia, many people even didn't know where Ukraine is. It was non-EU country that was not that much known for the world. However, we managed to involve patients from all over the globe to come into Ukraine for the IVF treatment. And I will tell what worked for this. And I learned already about Mexico, being here and visiting the clinics, talking to the doctors. So I understand the fact that Mexico is very similar to Ukraine in terms of the fact that this country may involve a lot of international patients to come. Because of the regulations, which are friendly for the international patients, for allowance of the different methods and different techniques being used in this country, because of the quite friendly costs for the treatment of the patients and high quality of this treatment. So I have nothing to disclose, but I am IVF doctor. Since 2006, I'm practicing IVF. I am partial owner of the clinic, so clinic is in Ukraine. And we feel and we believe everything will be good there. However, soon we will continue all our development. However, temporarily we moved into Slovakia, into Europe, and we moved by our biological materials because we were responsible for this. And this is very unsafe in our country right now, independently in which part of the country we are located, or the clinic is located, or people are located. So it's really dangerous. So, and we were responsible for all these biological materials, and patients were extremely feeling unsafe. They started to call, they started to reach us, sending emails, asking what's going on with our materials. So we moved them out, and we continue treatment for them in Europe so far. So if we are talking about the need for IVF treatment from individual patients is huge. If we are talking about special numbers, so it will be 90 million people every year annually looking for the treatment of IVF. Not all of them will get an access, not all of them will be able to afford this. However, like half of these people, this is something what is going on globally, annually in every country or in all together. And if we are talking about the need of the third-party reproduction, and by third-party reproduction we understand the need of the oocyte donation, and it's happening because generally age of our patients is increasing and they cannot produce healthy oocytes. There is a growing tendency for the same-sex couples, and they need an involvement of the third-party reproduction. There are technologies which are quite new and which are very interesting and which are very promising. However, they also need to involve the third-party reproduction. So in different clinics, this percentage will be different. I don't know what will be your practical experience. Like in your clinic, either that will be 5% of third-party, you are doing 15, 30. I would need to learn about this. However, it was 10 years ago, and this percentage is growing and growing, meaning if we have a good third-party reproduction, egg donation, surrogacy treatment, etc., meaning you can increase the flow of your patients significantly. So, and if you are talking about medical tourism, so the facts are here in terms of the numbers, but we are not that interested in numbers because it's not like we are doctors. So if we are talking about medical tourism influences and the reason why patient would think to travel somewhere to get an IVF treatment, so mostly they are looking for the higher quality of care and services. And this is both care and services. That's very important from our practical experience. We being Ukrainian, we are hosting patients really unique. We talk to them, we take care from the fact they are booking their tickets, they are booking their taxis, they are going to travel, they are going to be accommodated, they are going to receive medications, etc., etc. So you need to have a team, not just the doctors, but a care team who will talk with these patients if they are not with you 24/7, but this team will be 24/7 and communicate with them and guarantee for them care service. And the quality of the treatment as well, of course. So that's already responsibility of the medical and the embryological team. You need to control your KPIs, you need to know that you are good and you are improving, and usually you should compare us with us previous quarter or previous year. We should not compare us with someone else on a different side of the city or different clinic or different country. If you want to improve, we are improving steadily, constantly, but we are improving comparison how we were before. And that's for each individual, for each doctor, for each embryologist, for everyone. Medical treatment, if they are combined with the attractive destinations, I should say Mexico is quite interesting destination and quite attractive. So we can also put a sign here. Reduced costs in terms of the costs in the local country where patients live. And as for me, the challenge here or the opportunity here is the IVF market from the USA and Canada. So they are gladly come here for high quality, high care IVF services. And I know they are coming a lot. So this is where at least you can be focused. And the treatments or the medications or services which are not approved or legal in the home country where patients are. And I should say that this last point is the most influencing, because we know the regulations all over the globe and we are going to talk about them. And these regulations are making the fact that if this patient is Rokitansky, for example, and she lives in Germany, she will not be able to be treated there. So her only future is to live without child. If she wants to be treated, she needs to look for the surrogacy treatment. For the surrogacy treatment somewhere, maybe in Mexico, if not in Ukraine. So that's why if we are talking about legal aspects, so these benefits and the facts that the regulations are friendly for the IVF community are really, really very important. So what worked for Ukraine, and you can just copy this for Mexico, I think, that legal egg donation and surrogacy was there, it was in the law, and that was official. We had also approval for the experimental treatment techniques, and I will be mentioning mitochondrial donation later today. So this was all done easily and officially, formally. Best pricing policy, if we are comparing to European countries, because we are relatively closer, like we are far away from here, but we are very close to Europe, and comparable to another countries, we were more affordable. We were not cheaper, and we were not, it's not about like how we create the costs, but that was something what we paid to for our services, to our team, to our disposables and media, and to our donors, for example, and then we made a price, and that was affordable, and we just presented this to the patients. No visa required, so that was easy to get into the country, also very important. Excellent success rates. I've been talking with the professor here from Argentina that in Ukraine, for local patients, there was everything paid from the pocket. And we are not the richest country, like comparable. So sometimes me being a young doctor, I remember the whole family coming with the young woman, or relatively young woman, saying, this is the whole money we collected for IVF, please do your best, doctor. So that was our responsibility, and we really searched for the best opportunities, for everything the best we could do, and then we transmitted this just for multiple number of cycles, and this worked perfectly. No waiting list. We tried to do our best, and a lot of number of donors and surrogates immediately available, and we've been, I remember 2019, we had over 700 cycles for international patients coming from over 35 countries. That was the best year, 2019, before COVID started. And the reality now is absolutely not the same. Like we are making 10% of these activities just for local patients, that's it. And egg donors with extraordinary beauty and proven fertility. So by law, our donors, they should have a child of their own. And we already, because now we are recruiting donors and involving them from different parts of Europe and different countries, where not obviously they need to have a child. And we already compared the outcomes. So there is a slight difference, not a huge difference, but there is a slight difference. The fact that if they are proven, this works better. And in terms of the phenotype, so we have the mostly common requested phenotype from each parties of the globe, because we developed Ovogene as something what we understood that we can help more patients if we create an egg bank, and then there is a need for egg donation globally, and we send these eggs for the treatment to different destinations. And the most common phenotype which is needed, blue or light eyes, and blonde hair or light hair. So this is, we are like all Caucasians, we have different phenotypes, but most are very similar, like you can see me. So that's something what worked and what will, I hope, works for the future. So, and this is something what helped us. It was an independent source, like a recommendation for the patients from Europe who are looking for this treatment somewhere in different destinations, like a medical tourists. And we were proud to be like #2 after Spain. Of course, we all know Spain. Spain was destination #1 for many, many, many years. So Ukraine was not got into the #2. However, now again, it's not. That was end of 2019 and beginning of 2020 during the COVID. So it's changed. So if you're talking about focus of our patients, there is always success rate, time, and the reasonable cost. If you're talking about overview of the regulations for the different countries, so we are following all the regulations, and we have at Ovogene, we have a team like a compliance and quality who are tracking all these changes, because we need to correspond with the regulations of the countries to where we are going to supply the biological materials, but we are just following this just to be updated. So you are well aware about the United States regulations, that they are varying from state to state. However, they are covering the general, what can be done, what cannot be done. It's different from European Union, for example, because we have European directives, but under these directives, we have a country law regulations. And then the country law regulations, sometimes they contradict with the European regulations. European regulation says this is not allowed, and then the country regulation says it can be done. So United Kingdom is very well regulated, and the IGFA is covering not only local treatments there, but also third-party reproduction if there is something coming from the overseas or needs to be imported or exported. So they really control this well. And both countries, they have wonderful statistical data. They are collecting all the data, they know the efficiency, it's very transparent for their patients. Australia, National Health and Medical Research Council, also varies from state to state, but quite well regulated, as well as Canada. European Union, as I said, like different regulations in the country. China, not much allowed, like quite limited in terms of what they can do in China. That's why a lot of medical tourists coming from China to different destinations. I don't know how much here, but in Ukraine, we used to have them quite a lot. India, you know that they are regulated, however, they just recently, or not that much recently, but some time ago, they've been the surrogacy, which was a huge part of their activities in IVF, and the Middle East mostly regarding the Islamic fact of the religion, so that influences also the fact what they can do or cannot, and also Middle East patients are traveling quite a lot. And the European countries, as I said, like something what is most important, that Germany and France, there is no option for egg donation, no option for surrogacy within the European Union, so they are also traveling a lot out. Turkey, no egg donation, no surrogacy, so as well, Emirates, etc. So if we are talking about third-party services, they are, we know, oocyte donation, regular oocyte donation. Let's say there is a woman who is going to donate her eggs. She's going to be stimulated. Either she is located in the place where patients are going to be treated, or she is traveling there. There is a lot of, we know, a lot of fresh donors traveling to different destinations. From Ukraine, they've been traveling to Cyprus, to even to US if they have passport, etc., because it's different. This is work of agencies. We are not touching this a lot. However, there are a lot of regulatory and ethical aspects there. So agencies who are not medical practitioners, usually they do not take such a great care for people as we clinicians do. So, and we are aware about some facts when there was risk for these women being involved in this. And then we were lucky learning about oocyte vitrification 2011, 2012. It was no longer being experimental because it was quite a long time experimental. And now we are so successful in freezing, vitrifying, and sewing biological materials. We can avoid traveling, unnecessarily traveling, for example, of patients. We can freeze something here and send it over. This is what we do, and this really works well. We need to involve laboratory staff, and they need to follow the algorithms. They need to be really good in vitrification and sewing, but this comes with the practical experience. And now the process is absolutely efficient. And the commercial or surrogacy agreement, like compensated surrogacy agreement, since 1980, and officially now it's developed in the different countries and works globally. I don't know how much you're interested. It's a general table regarding if there is a possibility to treat single women, to use sperm donation, egg donation, if donors should be open ID or closed ID in different countries from Europe, because this is where we have a lot of our knowledge and data. If pre-implantation genetic diagnosis is about embryo adoption, post-mortal IVF, and the sex selection. So if we are talking about ethical aspects, we need to understand that involvement of these women who are going to be part of this IVF treatment is very important. And this needs to be done properly, in the proper way. And sometimes the compensation, what they are receiving, like financial compensation, this is something what forcing them to make a decision. And it's not a totally altruistic, we know this. However, we need to take great care for them. This is really very important. So I will share with you how we recruited our donors in Ukraine and how we do it now for Eastern Europe. We have a non-profit organization. It's a public organization which has a website. We have a team there of medical coordinators, involved doctors, psychologists, accountant, lawyer, and all these people, they communicate with these women who are going to be involved in the third-party reproduction. So we make for them the consultation, we educate them about the process, how the process will look like, what are the risks, what are the benefits, etc. And we help them to navigate during all the process and understand this. So they have a lot of resources where to read or to talk with other people involved, absolutely privately, and this is how they benefit. So they understand, and they are, what is important, they are well informed, and they have their decision made after receiving all this information, and we value what they do. Because in Ukraine, before the COVID started, there was a huge competition between the clinics. Like having this number of patients, international patients, we needed these donors and the surrogates. So we involved them, and they were communicating between themselves. They have their groups, chats, Telegram channels, WhatsApp channels, and they were saying, you can go to this clinic, they really take care, they will pay you what they promise, they will communicate with you, it's safe, etc. And don't go to this clinic because they are not that good as this one. So this is about reputation, not only for patients, but also for the third-party reproduction candidates. This is very important. So I know you also involve patients here, like in this donation, so that's the great advice, which works. So we had in Ukraine 16 centers, and now overseas we have 8 centers, so it's over close to 30 centers now. So we just implemented this practice and this way we are doing this into all the centers, and this just great. In terms of the advertisement, that's internet, local recruitment, TV, radio, and the most important is being your friend. So if they had a great experience, they will recommend their colleague, sister, friend, whatever, and this will work for them. Motivation, what we learned, of course, this is finance. However, very important is the fact that they are getting full screening for free. In order to make the full screening, again, they need to pay, because in our country and the countries we involve donors right now, if they want to know they are healthy, they need to come commercially and pay for this. And this is like a huge benefit, which we educate them about this as well. It should be safe and reliable. They should not wait, because we are egg bank. So as soon as she's screened, we involve her into the program. So her time, there is no waiting time. She come, we decided she's okay, she is screened, and then she donates and she's receiving her compensation. So we are saying this is a compensated altruism. It's not something what really forces the finance, nothing that forced us to make a decision. In terms of the ethical concerns, there is a frequency, how often we may stimulate our donors, how many times they can be a donors, if this brings them to some risk or there is no risk, and how we control the number of kids globally being born from this donor. Probably you've heard the huge, there was in news everywhere that in the Netherlands there was a sperm donor donating over 500 times, and that raised huge concern regarding the control of the number of kids born globally. So we made the statistical calculations on we have donors in our database who donated 6 times, and by the European law recommendations, they are donating up to 6 times. So we compared the outcomes from the first 3 cycles to the cycle number 4, 5, and 6, and you can see that, of course, donors were younger if they had first to third cycle, and then they were older. However, the fertilization rate of used blastocyst and the clinical pregnancy rate were not significantly different. So there is no impact in terms, and we are following at least 3 months in between the stimulations. So they can do 6 stimulations during, usually it was in 3 years time. So the results are absolutely identical, and there is no risk also for the health of the donor, because we understand there is no oncological risks, we are not causing premature menopause, etc., etc. And in terms of the number of, how we control the number of kids being born, so we have on the quarterly basis, and I hope in this line there will be Mexico soon. We are trying also to get in touch with some clinics if they have a need, but I believe they should have a need in our phenotypes and in our donors. So far we don't have it here on the map, but we know how many samples we sent to the different destinations globally. And we also know, so there is a code of the donor, and you know how many times she donated, how many eggs she produced, and to where these oocytes have been sent. And then we know the regulations in terms of how many babies can be born through oocyte donation in this country. For example, Macedonia is a very small country, and they allow only 1 donation. So if we know she donated there and we have the outcome, there is a clinical pregnancy, we cannot involve this donor anymore for donating in Macedonia, but for other countries she still is okay. Romania, being in EU, they have allowance of 5 donations. So this particular donor can be sent 1 more time to Romania, and then only after the clinical outcomes received. So if they used all the eggs, all the blastocysts they created, and there is no clinical pregnancy, meaning she is potentially 1 more donation, but not more. So this is also important. Regarding the medical concerns, there is as I said on the beginning, like the regulations in different countries, and they clearly state what needs to be there in terms of the screening, psychological screening, genetic screening, different evaluations, fact of it should be quarantine or not. So knowing this and following this, we make our donors and the material compliant with the regulations of the different countries. However, in terms of the involvement, this is 1 quarter statistic, and if we had 841 initial contact with the initial potential candidate, only 319, like 1/3, after we educated them, after they learned what will be the process and they agreed on the process, they decided to go further for the investigation and the screening. And then out of this, if we do the medical screening, like the IMH, and we do IMH for all our donors, and the antral follicle count, again, some donors will not be suitable, because if their IMH is less than 2, we are not including them in the program. And then some will be excluded after the infection disease screening, and few after the genetic consultation and the genetic screening. So roughly, we are getting 3 out of 10 initial contacts being approved into the further stimulation and the donations. In terms of the psychological evaluation as well, I believe this is also very important. We need to know the fact that she's psychologically proven, but also we need to cover the concern of the interest of the donor itself, so interest of the recipients, donor program and the clinic in general, so everyone who will be in touch with this donor, and the future child. There is a regulatory, like not general regulatory regarding the psychological evaluation, how it should be in most of the countries. So what we do a general psychological evaluation with some tests, and there is a report from our local psychologist. However, some countries, they request specific screening, like the MMPI, which is really hard to pass from the US, and the ANZICA counseling. So this woman who is going to donate, she needs to have a Skype consultation with the local Australian certified psychologist. We are translating for them, and only after this consultation she has been approved. So they don't allow to do this by anyone, like a third party or different psychologist, only proven psychologist by ANZICA. Regarding genetic testing as well, so we started from the fact that only karyotype needs to be done. And by law in our country, that was said, like inclusion criteria for the donors is this, 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 and that, and then the normal karyotype. However, after being working in this field, and if we are coming to the egg donation fact that they want a healthy baby, they don't understand if something will happen, and then one case delivering an unhealthy baby after oocyte donation, this is lots of complications. Even we understand that this can happen because every individual is carrying about 20 genes as a mutation. So until we don't screen this, we don't know this. So we decided to extend our genetic screening into the Fragile X, which is mostly very common, cystic fibrosis, SMA, and neurosensory deafness. And this was the recommendation of our genetician because that was very common in our population. Then we started to do thalassemia because that was requested from some countries, etc. However, that was not enough, as we understood, because some countries, for example, as US, they have already practiced to do extended genetics. And extended genetics has been done already in the US certified laboratories, and our donors, like most of our donors, they have more than 200 mutations. You see different Invitae panels or the Natera panels. And what we found that only 14% of those donors who has been proven fertility, young and healthy women, they haven't carried anything out of 200 genes. All others, like over 80%, they have been carrying some genes. And most common was cystic fibrosis variants, Smith-Lemel syndrome, etc. That's from the critical mutations. From non-critical mutations, hemochromatosis was very common, and some others, like in different distribution. However, the fact, and after we started to do this, and after we started to share this information with the physicians and with the clinics, they started to say, oh, okay, this donor is a carrier of something, meaning she is not healthy, we cannot involve her in the program. However, come on, if we will do extended genetics, and we have been doing 200 genes, if we will start do full exome genetic panel, or if we will do more, so we will be all carriers of something. So what we learned, that if we are doing extended genetics, there should be a matching between a parent, between a patient and a donor. And that will be a proper way how to perform this, and the proper way how we should guarantee that this baby will be born with less risks. Again, until we are not doing a full genome, we don't know if we are avoiding all risks. However, if we are doing extended genetic, we need to do extended genetic matching, and this is the proper way how to deal with this. However, we cannot say, no, we are not going to include these donors, because then meaning after having 30% just being in the database, and after excluding more than 80% from this number, we are staying with nothing. So regarding the infection disease screening, we do serology once we include them into the program, so we are sure they are not carriers of the HIV, hepatitis C, etc. However, some countries, they request, like IGFA, they request a quarantine. So what we do regularly, we do serology once they are involved in the program, then we redo serology on the start of the stimulation, and then we do NAT or PCR on the day of the oocyte collection. Meaning that should be absolutely safe, and we believe from the medical, microbiological understanding that that's enough saying this material is safe. However, some regulations are saying, no, that's not enough, you need to keep them in quarantine, and after 3 to 6 months, you need to repeat PCR again. So this is what requested by the IGFA, and so for this specific market, we are doing this like retesting of the critical infections by PCR after the quarantine. Regarding the stimulation protocols, so there is always a discussion regarding the appropriate number of the oocytes, and we believe in our practical experience, and I will show you the figures, that we cannot receive just few eggs from the donor. If we are receiving up to 10 eggs from the donor, this is not a proper donor, or that was not a proper stimulation. That should not be like this. So it should be a good responder, and the good responder in our hands and our KPI is between 15 to 30 major oocytes, which we are going to work with. And this is safe. We know the way how to provide this safe. We need to have the possibility to schedule. Why so? Because if we are busy laboratory and we've been in busy clinic, so we had a first half of the day stimulation for the patients, and then ICSI cultivation, etc. Then we had embryo transfer, and the second shift we have done the egg collections for the donors in order to distribute also the flow and the involvement of the embryological laboratory, because this is so important to control the timing since you receive the eggs until you vitrified and put them into the storage, and any timing in the lab. So that's why we need to know that one day we don't have two egg collections and another day 20. So it's so important. Mostly we do random start a lot. And I will share our data. I don't know how much you are using luteal phase stimulation. However, for us, it's like a very easy, and we are doing this commonly, like day-to-day practice. Safety and compliance is also very important. So in terms of what has been changed recently, once I started to do treatment, I remember we had only one choice. The choice was a long protocol with agonist and then the HCG triggering. And if you are having a good responders, which we used to have, then every second woman will develop OHSS. And I remember spending more time in the oocyte collection room, but collecting the Douglas, the liquid from the Douglas, instead of collecting the follicular fluid. And now we are happy to have another opportunity, which is safe. And our regular protocol is a short protocol with antagonist and agonist triggering. And we haven't seen OHSS. Since we started to use this, like more than 3 years now, any sign, like all this what we used to read, it was something what there was a different reason potentially. So we are not using HCG trigger for individual patients, low responders, yes, or combination of 2 triggers. However, for the good responders, never. It's a agonist trigger. Slow freezing, we are not doing, of course, we are doing vitrification and very successful in this. We do not recommend oral contraceptive pills because we saw clearly the connection with the fact one of our KPIs is follicular oocyte index. And if we are having short protocol with agonist triggering, if we are having low LH level, we know that the number of the follicles which we puncture and the comparison to the X will be lower. So that's why we are trying not to reduce their LH levels basic levels by giving them oral contraceptive pills. We are scheduling them with the progesterone or by using estrogen priming. Random start stimulations, as I said, and the progestin primed ovarian stimulations as well. Recently, we had some issues with the antagonist supply. So we are using dufaston all the way during stimulation, and they are not ovulating, and results absolutely great as well. So these are the comparison of the follicular and the luteal phase stimulations for the good responders. And I want to mention the age is between 21 to 32. So this is young women. IMH was in this particular group was over 3, even not over 4, over 2, but over 3. They had a minimum 1 stimulation protocol at Ovogene before that, before they've been included into this group. BMI was normal, and we used the same product, which is recombinant FSH for the stimulation. And you can see the total number of follicles in the cycle, 30, almost 2, and 35. No difference in the total oocytes collected, in the number of M2 oocytes, used oocytes, and so on. So why, even in the luteal phase, sometimes or quite often we see higher number of the follicles because of the asynchronization of the growth in the follicular phase. Sometimes we know quite often that it can be that short protocols give us asynchronic growth. And if we have a luteal phase start, we already have like the fact that there is a synchronical growth, and then it's better cohort, and they all grow absolutely great. We avoid only period when the dominant follicle is big, like between 15 and up, and the time after ovulation, like 2 days after ovulation. In any different time, we are starting the stimulation, and follicles are sensitive and they are responding for the FSH. In terms of the clinical results related to number of the received oocytes. So we made a comparison in the groups 1 to 11, 12 to 24, 25 to 30, and more than 30. So we evaluated that this group, which was the limited number of oocytes, produced the worst results in terms of the embryo used rate, and in terms of the maturation was the same. All characteristics were the same. However, the final outcome was not proper, meaning if we are stimulating a good responder, we need to receive an optimal number of the oocytes, and there was no difference if we are receiving over 30 eggs. We are not aiming to stimulate them to receive over 30. However, if you have this candidate, if you're starting even the middle dosage, like a total dosage of 2,000 or 2,500 during the whole stimulation, still you are receiving these numbers. So in terms of if you are talking not only about oocyte donation, however, about new and techniques which we are used, not commonly, but started to be used, we are using mitochondrial donation, doing pronuclear and the spindle transfer. And from the ethical concerns, I believe that this is the methodology which should be recommended to the patient before the oocyte donation, because this is the technology which still, we need a donor oocyte for this technology, because we are going to use a spindle from the mitochondrial activities and the environment of the donor egg. But what is happening? So if we are doing spindle transfer, so for, let's say, this is a woman who is 40 years old. She has IMH 0.3. She's still producing several eggs in her stimulated cycle. Let's say she produces 3 M2. Chances for her blastulation potential producing this 3 M2 would be, like, if she will be lucky, she will receive 1 blastocyst. However, not for sure. What we are doing, we are getting her spindle, and why she is not receiving? Because the mitochondrial activity is already very low. She is losing energy potential of her eggs by losing the activity of the ATF. So if we are taking her spindle, which consists the genetic material of this woman, her genetic material, we are putting the spindle into the donor egg, taking the spindle of the donor egg out and throwing this away. Then we do the fertilization, and then the spindle, which consists her genetic material, is developing inside of the donor egg. And this donor egg is giving a high potential for the blastocyst development. In our hands, it's between 60 to 70% blastocysts
rate we are receiving for these patients. Of course, we need to check if this blastocyst will be euploid after that. However, this is a great opportunity for them to develop their own genetic material in this age. If we are doing pronuclear transfer, this is very similar technique. However, we are making fertilization for both patient egg and the donor egg. And then day one, we are taking both pronucleuses from the zygote of the donor egg and putting them into from the patient egg, putting into the donor egg. And then the development is the same. Like inside the donor environment, there is a development of the nucleuses from the patient. It's very regulated technique. It's still considered to be experimental. It started to be allowed in the UK in 2015 because of the activity of one poor woman who lost 7 kids being sick with the mitochondrial disease. They were born, she was delivering, she was getting pregnant easily, she was delivering the babies, and all babies died until the age of 2. So she was the one forcing the IHFEA to allow this technique to be used. And just recently, The Guardian, the very known journal in the UK, they presented the fact that the first baby using this technique, because there is a lot of regulations there, has been born. But many groups in the different groups in the world, including our group, we are doing this as an experimental treatment under patient consent. And we do this not only for the mitochondrial disease patients, but also for advanced maternal age. Like if they want to try their last chance before doing egg donation, we believe that this is a great opportunity and this is the chance of carrying their own genes. Regarding surrogacy, it's also a lot of ethical discussions. We know the countries where the regulations allow surrogacy to happen, like the USA, Canada, and Mexico as well, Argentina, Greece, Ukraine, Georgia, or Kazakhstan. There is an altruistic surrogacy in Australia and the UK, and there is a longer list of the non-regulated countries, however, to where patients are going because there is not much to select from. Recently, Russia was closed just this year. So these changes are happening really, really fast in different countries. However, there are a lot of medical indications, like I said about Rokitansky, about patients with the removed uterus, etc. So there is an alternative, of course, we know regarding the transplantation of the uterus. However, it's still not it's easier to do surrogacy, I would say, than to transplant the uterus because of the costs, because of the regulations, and the fact that only few groups are doing this. So what is important here? Everything what we mentioned regarding egg donors, like the ethics and the safety and the fact that we are taking great care about these surrogate candidates. However, also the legal parentage and the citizenships. So we had some cases in Ukraine, if the lawyers were not controlling all the document side, etc., before providing the surrogacy treatment, then the baby stayed in Ukraine for the long period of time because they cannot be accepted. Like Italy, Spain, they have a huge and very complicated regulations in this matter. So for this, we need to have a cooperation between not only doctors and the patient, however, all different parties, and for this treatment specifically, there should be a legal part as well, very strong and very well involved from the very beginning. So if you're talking about, to conclude about cross-border third-party reproduction, it's a viable option for individuals and couples looking for the treatment and to the options to overcome their infertility. It offers a lot of new opportunities. However, sometimes it's regulated and it presents many clinicals and ethical considerations. There should be regulations and there should be a cooperation between the professionals involved in this in order to make it all safe and in the right way, because this is reputational issues, but that's a lot of opportunities for sure. Sometimes it's challenging. However, from our experience, I can say that you just need to start this. If you start this, if you're focusing on this, it's all possible and it's growing. You know, like we said, the best is the recommendation from the mouth of the world. If there is a patient who has been successful treated by you, they will share, they will present this experience, and that will work really perfect. So that's all I wanted to share today. If there are any questions, I'm happy to answer.